All right, welcome to part 5. Let's continue. Cardiac arrest in a child is one of the hardest calls as a rescuer that you may be asked to respond to. Know that the most common etiology for cardiac arrest in a child is respiratory based. All right. Children are affected differently by decreasing their oxygen concentration. As they go hypoxic, their hearts slow down and they become bradycardic and eventually go into respiratory arrest. I'm sorry, cardiac arrest. They go into respiratory arrest too. So shock, by definition, is hypoperfusion. It's a state where the circulatory system is unable to deliver a sufficient amount of oxygen to the end organs. Eventually, this will result in organ failure and death. Common causes of shock in children are infection, usually centered around their respiratory system. A pediatric patient also responds differently than adults due to fluid loss. So think about their blood volume. In other chapters in the trauma block, we talked about how a child does not have as much blood, and an infant especially can have as little as a soda can amount of blood in their body. As they lose fluid, they're going to increase their heart rate, they're going to increase respirations, and they're going to start showing skin signs of shock. Hypotension, low blood pressure, is a very late sign. And if you're seeing that, the patient, especially a pediatric patient, has probably fallen off the cliff already and is decompensating at that point. So, just like with an adult, we're going to treat the ABCs and assess them as required. The order changes to CAB if there is a life-threatening hemorrhage. So if you see that major bleed going on, you're going to treat that first before moving to the airways and breathing. It could be tourniquet, could be direct pressure, whatever bleeding control method that you're going to use. If you find it, that should come first. Okay. Again, pediatric patients, hypotension is a late and severe shock sign. Our management should be limited to simple interventions. You're not going to be doing a whole bunch for patients that are in shock. They need advanced treatment. They need a hospital. They need an ALS intercept if that is appropriate. Your treatment focus needs to be on the ABCs. Make sure their airway is open. Make sure their bleeding is controlled. Make sure they're breathing and ventilating appropriately as much as you can. Give supplemental oxygen as needed and by whatever route is needed. Okay, continue to monitor them, keep them warm, keep them in whatever position is most comfortable for them. Keep an eye on their airway, suction, bag, oxygen, any interventions as needed. And again, consider ALS intercept early on in that. We have a few more tools in the paramedic toolbox that can make a difference, but only if it's not going to actually delay their treatment. So it's a judgment call that you as an EMT have to make. Of course, there's always anaphylactic shock. That's an allergic reaction. We know how to treat those. The key is going to be epinephrine for these anaphylactic multiple organ system allergic reaction responses. And we've talked back in block 5 about bleeding disorders. We talked about hemophilia, generally congenital. Again, these are not commonly found, and when they are found, they're usually in male populations. They can have spontaneous and severe bleeding, probably not going to clot. We're going to use our standard bleeding control techniques, but depending on what type of hemophilia they have, they're going to need their clotting factors. They may have that with them, they may have them close by, but they can present as bleeding, and when that happens, they can go into hypovolemic shock if it left unchecked. So, AEIOU tips. You should know this mnemonic. This is a mnemonic to guide you along what is causing altered mental status in any aged patient. But it's especially useful in children if they can't communicate well. So, alcohol, epilepsy, endocrine or electrolytes, insulin, opiates or other drugs, uremia, kidney failure, trauma and temperature, infection, poisoning, psychogenic causes, shock, stroke, seizures, syncope, space-occupying lesions, that's a tumor, and subarachnoid hemorrhage. Seizures in a child present differently, quite dramatically different, depending on their age. So We're used to seeing seizures as full-body tonic-clonic ones, but infants may just have deviations in gaze. They may have an abnormal gaze. They may have a sucking sensation, lip smackling. Their legs may be going in a bicycling type motion. Those are not normal. None of those things are normal. And sucking in particular should only happen when there's something for them to suck on. If they're lip smacking or they're making that sucking kind of motion without any obvious cause, you need to think about a seizure in that. Obviously, as they get older, the seizure can become more obvious, that muscle contraction, that obvious tonic-clonic seizure that happens. Very common types of seizures are listed here in Table 34-12. Take a look through these. Keep all of these on your differential. The most common one, however, is probably fever. So we're going to talk about febrile seizures specifically in here. But any type there's a head injury, so abuse or trauma can cause seizures. Hypoglycemia can cause seizures. Overdoses, poisonings, if they have a known seizure disorder, those are all common causes of seizures in children. The longer and harder that a seizure is, the longer it takes for the imbalance to correct itself, if it will correct at all. Prolonged seizures can be life-threatening. We call that status epilepticus. Those are seizures that either don't stop or don't have any intervening lucid period in between, and those should be taken seriously. Management for that revolves around keeping them from hurting themselves and trying to keep their airway as clear as possible. We don't put things in their mouth. We don't put bite blocks in their mouth, but you can suction if they'll let you, if the jaw is not clenched. If it is, you can suction around the teeth, but we're not going to leave anything in their mouth. We want to put them on their side as much as possible to allow any drool, vomitus, blood from biting their tongue, for instance, to come out and not just stay in. Meningitis is an infection of the meninges, the tissue that covers your spinal cord and brain. It can be caused by fungal meningitis. It can be caused by bacterial or viral meningitis. Meningitis is something that in the correct form can kill someone very quickly. Sometimes as short as an hour from the time of symptom onset to death has been recorded, especially in bacterial meningitis. So who's at risk of this? Males are at greater risk, along with newborn infants. Newborn infant males are at a high risk there by definition. Anybody that's immunocompromised has a higher risk of that. Anybody that has had brain, spine, or back surgery anywhere near those structures is, of course, at a higher risk for meningitis. Head trauma, yes. Children that have anything foreign in their body, shunts, pins, anything like that that is near their brain and spinal cord is a potential vector for infection. So, the big severe one is Neisseria meningitis, that one, you see it up there. It's a bacteria that causes very rapid onset of these symptoms, and this is the one that will go from nothing to symptomatic and death in an hour. So have a high index of suspicion with some of these symptoms that you see, small, pinpoint, very red spots on their body, or a purplish black rash that's a little bit bigger over their body. That's what that looks like there. You see those rash spots. You know, adults may have skin that looks like this. It's not from meningitis. Children shouldn't. Okay? This is why doing a good physical exam on these patients is so important. So, standard precautions are important, okay? Because this can affect you as well as a rescuer. If a patient has meningitis, it is contagious. Okay, you should consider it to be contagious, and hopefully your whatever system you work in or the hospital will have a follow-up and infectious disease plan. Here in Albuquerque, the hospital is going to contact the people that were in contact with these patients and tell them, hey, this patient popped positive for bacterial meningitis. You need to get your people down to get checked right away. All right. So, abdominal pain. We've all had it. It's very unpleasant. Don't take these complaints lightly. Abdominal pain, as we know by now can be a sign or symptom of a significant underlying problem. It can be internal bleeding. It can be something that's going to become internal bleeding. It can be a sign and symptom of shock in and of itself. We're looking for distension. We're looking for rigidity. GI complaints are common in pediatric patients. Direct your history around, have they eaten anything new? Have they been around new material? Is there a chance that they have gotten into something that they have eaten that is now causing GI discomfort? Are they having nausea, vomiting, diarrhea, now or in the past little while? Appendicitis is also something you need to concern yourself with. If you suspect that, they need rapid transport to the hospital because it can lead to life-threatening shock, especially if the appendix ruptures, leading to septicemia and peritonitis. One of the hallmarks of this will be rebound tenderness. When you palpate their lower right quadrant, if it hurts when you push down and then when you let go, they scream and try to hit you, that's rebound tenderness. It's pain that's worse when you let go, when you remove pressure off of their abdomen than when you push on it. Poisonings are also pretty common among younger children, especially. They have a lot of common sources around the house, cleaning products that live under your sink or wherever. Children are curious. They're going to drink things. They're going to eat things. Older children, Tide Pods, come on. Well, I don't even understand how that was a thing, but it is. It can cause poisonings. So the signs and symptoms vary dramatically depending upon what the substance was, how old the patient is, their weight, whether or not the substance was fat soluble or not. It all depends. The type of toxin can dictate what's going to happen. So is it a CNS depressant? Are they going to become sleepy, lethargic? Are they going to have interruptions to their vital signs? Depends on the topic. If it's a medication, this is another common poisoning route for children, is they get into an adult's medication or their own. My very own mother got into a bunch of Tylenol when she was very, very young. It was children's Tylenol, and it was flavored, and it was candy to her, so she just ate it and ate it and ate it. Some medications can be lethal in just one pill. Okay, an adult concentration of a beta blocker, for instance, taken by an infant can cause significant cardiac problems. Be alert for signs of abuse in these situations. Was this done intentionally? That would be extremely sad, but we have to think about that. So, ask these questions of a caregiver after your primary assessment. Do you know what the substance was? Do you know how much of it they ingested? That, along with what time did it occur, is important because that can dictate whether or not they're going to be able to pump their stomach, give them something like activated charcoal, or if they're going to have to go to more extreme measures. What changes occurred? What signs and symptoms are we seeing, especially in changes in level of consciousness and behavior? And then, are they choking? Are there airway burns? Things like that present. Poison control is a good friend that you should use whenever you need to. 1-800-222-1222. Again, that's 1-800-222-1222. All right, I'll see you guys on the next section.